Choledochal cyst. A cyst in a bile duct may look simple, but choledochal cyst can lead to recurrent cholangitis, pancreatitis, and even increase the risk of biliary cancer. In this video, let's understand its type, clinical features, investigations, and management in a simple way. Hello everyone, welcome to DrSA, Doctor's Surgery Academic channel, where we simplify surgery and anatomy for students and medical professionals. So, let us start with the basics. What exactly is a choledochal cyst? A choledochal cyst is a congenital cystic or fusiform dilatation of the biliary tree involving the extrahepatic and or intrahepatic bile ducts. It forms because of partial or complete weakness of the CBD wall. It may be single or multiple cyst. During embryogenesis, there is an abnormal early canalization of the bile duct. It is often associated with pancreatico-biliary maljunction. Next point, pathogenesis of choledochal cyst. One of the important theory behind the formation of choledochal cyst is presence of an anomalous pancreatico-biliary junction. Normally, the pancreatic duct and bile duct join close to the duodenum. When they join abnormally, pancreatic juice can reflux into the bile duct. Because of the pancreatic juice contain digestive enzymes, can cause repeated injury and an inflammation of the bile duct wall. This enzymatic injury leads to weakening of the duct wall. The weakened bile duct then gradually become dilated, resulting in the formation of choledochal cyst. So, remember the sequence: pancreatic juice reflux, enzymatic injury, inflammation and weakening of the bile duct wall, progressive dilatation, choledochal cyst formation. The clinical presentation of the choledochal cyst can vary depending on the patient's age and the extent of biliary obstruction. The common symptoms include obstructive jaundice and pain, typically in the right hypochondrium. Some patients may also present with a palpable abdominal mass. These three features, jaundice, abdominal pain, and palpable abdominal mass, are classically described as a triad of choledochal cyst. In children, failure to thrive may also be seen, while patients with biliary infection can present with cholangitis. Now let us move on the classification of choledochal cyst according to the Todani Classification. They are divided into 5 main types, type 1 to type 5. Type 1 is fusiform type 2 saccular type 3 choledococele, type 4 fusiform with intrahepatic involvement, type 5 intrahepatic type. Let's understand each type one by one. First, we have type 1, the most common type of choledochal cyst. It is characterized by fusiform dilatation of the common bile duct. Now look at the diagram carefully. The entire extrahepatic bile duct is enlarged in a spindle shape or fusiform fashion. This is the typical appearance of type 1 choledochal cyst. Next we have type 2, also known as the saccular type. It is characterized by a lateral saccular diverticulum arising from the common bile duct. As you can see in the diagram, there is a sac-like outpouching from the side of CBD. This is the typical appearance of type 2 choledochal cyst. Next we have type 3, also known as choledococele. It is characterized by dilatation of intraduodenal segment of the common bile duct. Now look at the diagram carefully. You can see dilated distal portion of CBD. As it passes through the wall of duodenum, this cystic dilatation within the duodenal wall is called choledochal. Now comes type 4, where disease extends beyond the common bile duct. Here, both extrahepatic and intrahepatic biliary system are dilated. Focus on the diagram for a moment. You can see the fusiform dilatation of CBD along with the dilated intrahepatic bile duct. So, unlike the earlier types, type 4 involves both the extrahepatic and intrahepatic biliary tree. Finally, we come to type 5, also known as the intrahepatic type. Unlike the previous type, the dilatation is confined to the intrahepatic bile duct. In the diagram, notice the multiple cystic dilatations within the intrahepatic biliary tree. This characteristic appearance represents type 5 choledochal cyst, also known as Caroli disease. Complications of choledochal cyst. Choledochal cyst can lead to several important complications ranging from infection and stone formation to malignant transformation. Pancreatitis. Pancreatitis can occur particularly in type 3 choledochal. Suppurative cholangitis may develop because of biliary obstruction and infection, while bile stasis can predispose to gallstone and common bile duct stone formation. Long-standing disease can also result in secondary biliary cirrhosis. In severe cases, rupture of the cyst may occur, leading to bile peritonitis. One of the most serious complications is malignant transformation, particularly cholangiocarcinoma. The risk of malignancy increases with age and especially associated with type 1 and type 5 cysts. Chronic biliary stasis, reflux, recurrent infections, and an anomalous pancreatico-biliary junction are contribute to this malignant transformation. Importantly, the risk does not completely disappear after surgery. Malignancy can rarely develop in a residual cyst or even at the anastomotic site. Therefore, a choledochal cyst is not simply a benign dilatation of the bile duct, it carries significant long-term risk, which is why appropriate treatment and long-term follow-up are important. Investigations for choledochal cyst. The investigations for a suspected choledochal cyst include ultrasonography of the abdomen. Usually the initial investigation in infant, it may reveal a unilocular cystic lesion. CT scan helps define the biliary anatomy and assess intrahepatic biliary involvement. Hepatobiliary nuclear scanning helps evaluate bile flow and biliary drainage. ERCP and cholangiography provide detailed visualization of biliary tree and can demonstrate associated ductal abnormalities. MRCP, a non-invasive method to assess the pancreatic and biliary system and identify an anomalous pancreatico-biliary junction. Liver function test helps to assess biliary obstruction and associated hepatic dysfunction. Treatment of choledochal cyst. The treatment of choledochal cyst is primarily surgical, and the exact procedure depends on its type and extent of biliary involvement. For type 1, the standard treatment is complete excision of the cyst along with its mucosal lining, followed by reconstruction of the biliary drainage, most commonly with a Roux-en-Y hepatico-jejunostomy, so that bile drain from the liver directly into the small intestine. Type 2. The cystic diverticulum is excised and the opening in the common bile duct is closed primarily. For type 3, endoscopic sphincterotomy can be performed in the selected cases. However, larger or symptomatic lesion may require surgical or endoscopic excision. In type 4, the treatment depends on the extent of involvement. If part of the cyst is densely adherent to the portal vein, complete excision may not be safe. In such a situation, the adherent portion of the cyst wall may be left behind, but the cyst mucosal lining should be carefully removed to reduce the risk of recurrence and malignant transformation. Type 5 is more challenging because the abnormality involves the intrahepatic bile ducts. If the disease is localized to one part of the liver, hepatic resection may be sufficient. However, in diffuse disease with the severe complications, liver transplantation may be required. Cholecystectomy is generally performed along with the definitive treatment in all types because incidence of the gallbladder carcinoma is also high in these patients. Finally, if malignant transformation has already occurred, the treatment depends on the location and stage of the cancer and may require radical resection with chemotherapy. So the key principle is, whenever feasible, remove the abnormal cystic duct and establish safe long-term biliary drainage. So, to summarize, choledochal cyst is not simply a dilated bile duct. It is a condition with serious complication and a significant risk of malignancy. Understanding the Todani classification is essential because the type of cyst directly influences its management. I hope this video helped you understand choledochal cyst in a simple and practical way. If you found this video useful, please like the video, share it with your colleagues and friends, and subscribe to Dr. Surgery Academy for more easy to understand videos on surgery and anatomy. Keep learning, keep revising, maintain notes, and I will see you in the next video. Thank you for watching.